Hi everyone, my name is Alex Friedman and I'm one of the residents here at Women and Infants. Today I'm going to be talking to you about postpartum rounding. Today our goals include identifying the normal postpartum course, defining postpartum complications, learning how to gather information about patients, integrating and applying this information, and finally practicing assessing patients. Here are some helpful abbreviations that you will encounter throughout this presentation and also throughout your rotation. I will give you a moment to review them now. There are three main places that you'll get information about our postpartum patients. The first is the postpartum rounding sheet, which includes historical information, up-to-date vitals and labs, and the patient's medications. You'll also get information through speaking with your patient during your interview, which will allow you to clarify their history and assess for symptoms. And finally, through your physical exam, you will assess for patient recovery and check for complications. Let's start with normal postpartum care. Patients who have a vaginal delivery typically go home on postpartum day 2 and have a faster recovery than patients who have cesarean sections, who go home on post-op day 3 or 4. When considering wound infections, patients who have vaginal deliveries may have vaginal lacerations versus patients with cesarean sections who have incisions. Both kinds of patients need usual postpartum care. Slightly different parameters are considered normal in pregnant and postpartum patients. Advanced maternal age is considered greater than 35 years, and these patients will require additional screening during pregnancy. Pulse is tolerated to 110 beats per minute, and leukocytosis is considered greater than 15,000. Hemoglobin supplementation typically only occurs at hemoglobins less than 9. Temperature, blood pressure, respiratory rate, and platelet counts are all similar to non-pregnant patients. Before patients leave the hospital, they must be meeting certain milestones. Here is how I ask about those milestones in the morning. Are you eating like you would at home? Are you peeing without pain? Are you passing gas? Have you had a bowel movement? Of note, patients do not need to have a bowel movement before they leave the hospital. Have you been able to get up out of bed and walk around? Is your pain better with the medicine? How is it on a scale of 1 to 10? Is your bleeding more or less than a period? How are you feeding your baby? Any difficulties? What have you considered for birth control after this pregnancy? And what options do you know about? The final 2 points on this list are beyond the scope of this presentation and will be addressed at different parts of your curriculum. Here you can see an example of a normal patient on the postpartum rounding sheet. This is a 30-year-old G3P3 who had a vaginal delivery with a normal blood loss. You can see her breastfeeding and birth control plans listed here. Her vitals and her labs are all within normal limits, and she's on routine medications. All postpartum patients should have a physical exam. You should assess their general appearance, listen to their heart and their lungs, press on their abdomen, and check their fundus in relation to the level of their umbilicus. And you should check their extremities to make sure they are warm and well perfused without calf tenderness, though edema can be normal in the postpartum period. The residents will be assessing the pelvic pad for patients to check their lochia. You should never check a pelvic pad or do a breast exam without a chaperone, and if you have concerns, you should ask a resident or a nurse for help. Here's an example of a summary slide that you'll be seeing throughout this presentation. It will refer to the information you should find on the postpartum rounding sheet, what you should ask in the interview, and then demonstrate what exam maneuvers you should perform. Now let's move on to postpartum complications. This presentation will review the 4 main postpartum complications: postpartum hemorrhage, preeclampsia, endometritis, and postoperative infection. We'll start with postpartum hemorrhage. Postpartum hemorrhage is defined as greater than 500 cc's blood loss after a vaginal delivery or greater than 1,000 cc blood loss after a C-section. Postpartum hemorrhage can lead to dangerous results including shock, DIC, and even death. Uterine atony is the most common cause of postpartum hemorrhage and can be caused by uterine fatigue from prolonged, augmented, or rapid labor or chorioamnionitis, or may be caused by uterine distension, that is multiple gestations, macrosomia, or polyhydramnios. Retained products, where a portion of the placenta remains inside, can prevent clamping of the uterus and stopping bleeding from the spiral arteries. The most common risk factor is manual extraction of the placenta. And finally, lacerations may cause postpartum hemorrhage and are more common in difficult deliveries using forceps or vacuum or with a shoulder dystocia. Other rare causes include clotting disorders and uterine inversion. Let's look at an example of a patient who you might encounter during your postpartum rounding. Take a moment to review the patient's history, identify any risk factors, identify any abnormalities in her vital signs, her labs, and any medications that might alert you to what's going on. When looking for risk factors for postpartum hemorrhage, we should examine the history for parity, a history of chorioamnionitis, uterine atony, and the estimated blood loss. We should look at blood pressure, pulse, and hemoglobin, and see if the patient's on any antibiotics or if they've received uterotonics. We see here that this patient had chorio, was treated with antibiotics, and had atony requiring methergin. Her blood loss was 600, which is consistent with hemorrhage. Her pulse is elevated and her hemoglobin is low at 8.2, and you can see her uterotonics listed below. Now consider what physical exam maneuvers would be important and what interview questions you would need to ask the patient. When we assess our patient in the morning, we should ensure that her bleeding is less than a pad per hour and should check to see if she's symptomatically anemic, that is, lightheaded, dizzy, or feeling her heart race. We should ensure her abdomen is soft, her fundus is firm, that her bleeding is well controlled, and we should check her lacerations. We will now move on to preeclampsia. Preeclampsia is a hypertensive disorder of pregnancy defined by systolic pressure greater than 140 or diastolic pressure greater than 90. Severe preeclampsia is defined as systolic pressure greater than 160 or diastolic greater than 110. Treatment includes magnesium and delivery, and blood pressure should be taken manually in order to be accurate. Preeclampsia affects all systems in the body. Neurologically, it can cause headache, changes in vision, hyperreflexia, and seizure. In the blood, it can cause decreased platelets. In the liver, transaminitis and right upper quadrant pain. In the kidney, increased creatinine and decreased urine output. In the lungs, pulmonary edema. And finally, in pregnancy, intrauterine growth restriction and oligohydramnios. There are several risk factors for preeclampsia, including demographic factors like first pregnancy, advanced maternal age, and African American race, pregnancy factors like history of preeclampsia or multiple gestations, and finally medical conditions like obesity and chronic hypertension and diabetes, as well as any other disorder that could affect the vasculature, connective tissue, or the kidneys. Let's now look at our next patient. This is a 38-year-old G1P1 who had a cesarean section for failed induction of labor with preeclampsia. She has type 2 diabetes, and she had a blood loss of 500 cc's. What do you notice is abnormal in her vital signs and her labs? When assessing the postpartum rounding sheet for signs of preeclampsia, we should check a patient's history for pregnancy-induced hypertension or chronic hypertension. We should check for their blood pressure, platelets, and hemoglobin, as well as medications including magnesium and antihypertensives. We should also look for other labs that would indicate preeclampsia. Here we see our patient has a history of chronic hypertension and had preeclampsia during her delivery. She also has a history of type 2 diabetes, all of which put her at risk. Her advanced maternal age, and this being her first birth, also put her at risk. We can see that she has an elevated blood pressure and low platelets, and she's been treated with antihypertensives. When interviewing this patient, we should ask about the symptoms of preeclampsia, including headache, changes in vision, pain on the right side under the ribs, and swelling. We should ask about shortness of breath and any history of preeclampsia or problems with blood pressure in pregnancy. On exam, we should listen to her lungs and ensure there are no crackles, assess for right upper quadrant pain, check for reflexes and clonus, and check for edema. We will now review endometritis. Uterine infections can be divided into two categories: chorioamnionitis, which occurs before delivery and is treated with gentamicin and ampicillin, and endometritis, which occurs after delivery and is treated with gentamicin and clindamycin. Risk factors for endometritis include a long delivery, prolonged rupture of membranes, and manual extraction of the placenta. Endometritis is a polymicrobial infection and therefore antibiotics should treat gram-positives, negatives, and anaerobes. Let's look at our next patient. This is a 22-year-old G2, P2, who had a primary C-section for failed induction of labor. It was for premature rupture of membranes, and she had greater than 24 hours in labor. What abnormalities do you notice in her vital signs and in her labs? When assessing a patient for endometritis, we should look in their history for premature rupture of membranes or manual extraction of the placenta. We should check their temperature, their pulse, and their white blood cell count and see if they're on antibiotics. We can see our patient was induced for premature rupture of membranes and had greater than 24 hours in labor. She has a temperature of 38.4, she's tachycardic, and she has a leukocytosis. We also see at the bottom of the page that she is on antibiotics, gentamicin and clindamycin, treating her for endometritis. When we interview her, we should ask if she feels feverish, if she's had any foul discharge, or if she's noticed any increased pain. All signs of endometritis. On exam, we should check for fundal tenderness and foul discharge. We'll now review post-op fever. There are two main categories of post-op fever sources. Pregnancy causes we will address later, and general causes we'll discuss now. Some use the acronym WIN, Water, Wound, Walking, Wonder Drug to remember the 5 main causes of post-op fever. These help us remember pneumonia and atelectasis, UTI and pyelonephritis, incision and vaginal lacerations, DVT and PE, and finally misoprostol, a medication that's sometimes used in postpartum hemorrhage that can also cause fever. Here's an example of a patient you might encounter while postpartum rounding. What risk factors can you identify from her history? What abnormalities do you notice in her vitals? And what abnormalities do you notice in her labs? What medications may help to know what's going on with her? When assessing patients for post-op fever, we should check their history for risk factors like cesarean section, obesity, or lacerations. We should check their vitals and labs for temperature, pulse, respiratory rate, and white blood cell count. We should assess their medications to see if they're on antibiotics or any fever-inducing medications. This patient has the risk factors of obesity and a repeat C-section. Her temperature is elevated at 38.4, her respiratory rate is 22, which is high, and her white blood cell count is 18.9. I do not see any medications on her list that would put her at risk. Now think about what exam maneuvers you would perform and what questions you would want to ask the patient. When interviewing a patient, we should assess for cough, shortness of breath and sputum production, dysuria and flank pain, changes in the incision, and calf pain or chest pain. We should check to see if the lungs are clear, if they have suprapubic or CVA tenderness. We should check their wound and check for calf tenderness. Additional labs may be helpful, including a BMP, a urinalysis, checking the urine output, and checking a repeat CBC. Other tests may include a chest X-ray, an EKG, and lower extremity Dopplers. Now that we've reviewed common abnormalities, we will go over how to assess patients. The following slides will show common abnormalities on the postpartum sheet and will help you make a differential diagnosis and determine the most likely cause of the abnormality. We'll start with tachycardia. As mentioned earlier, tachycardia in the non-pregnant population is defined as greater than 100 beats per minute, but in the pregnant population is greater than 110. The differential for tachycardia is broad and includes cardiopulmonary sources like PE and cardiac arrhythmia, infectious sources when it occurs with fever, decreased volume status either from dehydration and under resuscitation or blood loss, and other causes including pain and anxiety. This is an example of a patient that you might encounter while postpartum rounding. Check her history for risk factors and assess her vital signs and labs for abnormalities. Finally, check her medications for anything that might give you a clue as to what is going on. As you can see, this is a patient who had chorioamnionitis treated with antibiotics and atony requiring a uterotonic. She is tachycardic to 117 and is anemic with a hemoglobin of 8.2. You can see her antibiotics and uterotonics listed below. What questions would you like to ask this patient, and what physical exam maneuvers will you perform to better assess her complications? Your differential for this patient should include cardiopulmonary sources like PE or cardiac sources like an arrhythmia. We should assess for hypovolemia, including under resuscitation and blood loss. And finally, we should check to see if she feels anxious or if her pain is controlled. On exam, we can check for pallor, do a heart and lung exam, assess the patient's bleeding, and check for calf tenderness. To better assess the patient, labs including a BMP, urinalysis for ketones, and repeat CBC may be helpful. Additionally, lower extremity Dopplers, EKG, and a check of the urine output may be important. Now let's review hypertension. Hypertension is defined as a blood pressure greater than 140 systolic or greater than 90 diastolic. Severe blood pressures include a systolic over 160 or a diastolic greater than 110. Treatment can be initiated with several agents for severe range blood pressures, including nifedipine, labetalol, or magnesium for preeclampsia. Blood pressure should be taken manually to be accurate. Hypertension can fall into several categories. If a pregnant patient has hypertension before 20 weeks, it is considered chronic. If that blood pressure is developed after 20 weeks, it's considered pregnancy-induced and may be either gestational or preeclampsia. Elevated blood pressures may be an error if they're taken with an automatic cuff or may be caused by pain or anxiety if they occur during a contraction or painful procedure. Here's another example of a patient you might encounter while postpartum rounding. What risk factors do you notice in her history? What abnormalities do you see in her vital signs, in her labs? And what medications help you to understand what's going on with this patient? When assessing a patient for hypertension, you should check their history for pregnancy-induced hypertension and chronic hypertension. You should check their vital signs for elevated blood pressure and their labs for platelets and hemoglobin. You should also look into an AST, ALT, creatinine, and P/C ratio. You should see if they're on any medications like magnesium or antihypertensives. Here, our patient has a history of hypertension, as well as preeclampsia in this delivery, and type 2 diabetes. She's of advanced maternal age and is a nullip, all of which put her at greater risk. Her blood pressure is elevated but non-severe, and her platelets are low. She has required IV labetalol to help control her pressure. Now think about what questions you would like to ask this patient and what exam maneuvers you would perform. When interviewing the patient, we should ask for symptoms of preeclampsia, including a headache, changes in vision, right upper quadrant pain, swelling, shortness of breath, and we should ask her about her history of preeclampsia or hypertension. We should check to see that her lungs are clear. We should assess for right upper quadrant pain. We should check her reflexes and assess for clonus, and finally check for edema. We will now discuss fever. As mentioned earlier, fever can be broken into two categories, those that are specific to the pregnancy or postpartum period, and those that have to do with general post-op status. Pregnancy-specific complications include those of the breast, including engorgement and mastitis, both of which can result in fever. Infection in the uterus or endometritis may also be the source of fever in the postpartum period. Here's another example of a patient you might encounter while postpartum rounding. What risk factors do you notice in her history? What abnormalities do you see in her vitals and her labs? And what medications help you to know what's going on with this patient? When assessing patients with a fever, you should check their history for cesarean section, obesity, and breastfeeding. You should look at their temperature, pulse, respiratory rate, and see if they have a leukocytosis, and check their medications for antibiotics. Here, our patient has the risk factors of obesity and a repeat C-section. Her temperature is elevated, as is her respiratory rate, and she has a leukocytosis. She is not yet on antibiotics. What questions would you like to ask this patient, and what exam maneuvers would you perform to better clarify your differential diagnosis? Your differential should include breast source, endometritis, wind, water, wound, walking, and wonder drug. You can assess if she has breast pain or redness, foul discharge, cough, shortness of breath or sputum production, dysuria or flank pain, changes in her incision or her laceration site, calf pain, or chest pain. You should do a breast exam, check to see if her fundus is tender or if she has vaulochia. You should check her lungs to ensure that they're clear, check for suprapubic and CVA tenderness, inspect her wounds, and check for calf tenderness. What additional labs would be helpful? A BMP, urinalysis, and repeat CBC may help you to assess what's going on with this patient. A chest x-ray, EKG, lower extremity Dopplers, and urine output may also help you to make your decision. And now let's finish with a quick review. Today we've reviewed the normal postpartum course and postpartum milestones. We've discussed the 4 main postpartum complications and how we can find patient information, including on the postpartum rounding sheet, the patient interview, and the exam. We've used preliminary data to make a differential diagnosis and then practiced using our interview and our exam to draw conclusions. Thank you so much for your time today. I hope that you found this presentation helpful. You're of course welcome to contact me with any questions. Thank you.